So on the tables, and I'm not sure, there's a case study we're going to do for burns, because that kind of covers the content that's actually for that burn area. So, I don't know if everybody got one.
This is the actual one here. Anyone needs it?
I think, Kim, do you have one?
Oh, no, I don't.
Here.
All right. So this is an example of kind of, last week we kind of went over it real quick just to kind of give an overview about what was going to be on assessment 4, which is burns in GU. So think fluid and electrolytes, major kind of concept that's going on with this one. But we talked about burns and what areas and things that our patients are that you have to look for. So I thought an easy way to kind of pull it all together today was just to kind of do a case study on it. So we have a patient, WT is 38-year-old truck driver who was driving a fuel truck this morning on I-4. A car cut him off, causing the truck to go into a spinning crash. Fuel was leaking from the tank compartment and started a fire. WT was trapped in the cab of the truck. Several motorists who had fire extinguishers put out the fire and were able to pull him out of the truck. EMS and fire rescue were delayed in reaching him due to traffic delays associated with Irma relief planes.
Really?
They finally reached him an hour later.
Dang.
On arrival, he was placed on a non-rebreather mask, his neck placed in a collar, and a backboard applied. An IV of lactated ringers at 250 an hour was initiated. He has partial and full thickness burns to his anterior trunk and both arms. Vital signs were 97.2, heart rate of 138, respiratory rate of 38, BP of 122/60. He's complaining of severe pain and not being able to catch his breath. He has vomited once. His stretcher weight is 188 pounds. So that's our patient scenario with a burn injury. Now, we talked last week about, there's different mechanisms how patients get burned. It can be flame, steam, cold, electricity. So a lot of different mechanisms of injury that can happen with a patient, but certain things we have to look at and monitor as far as how we care for the patient. So in this case, question 1 is, what are the immediate priorities related to WT's care?
Fluids.
Fluid resuscitation.
We got to do fluid resuscitation because that's important.
Oxygen.
Yeah, oxygen.
Heart rate is high.
We need to address his heart rate. Anything else we need to do for him immediately?
Pain.
Pain, because he's crying out in pain. Those are things that we got to kind of look at, those physiologic things that happen to the patient. Now, he was in a car accident, so what other stuff do we look for? You look for anything associated with trauma. So you are going to do an examination, look at his abdomen, feel it, see if there's any tenderness, if there's any guarding, if he has a board-like abdomen or rebound tenderness. Those things tell you there might be a perforation that is there. Those are things that you're looking for. You look for deformities, because if he had any fractures, those are things you're going to see in his extremities. So you look for deformities of extremities. Now, even though the people put him out, because remember they had fire extinguishers and put him out, you also have to think about that was likely associated with some type of the oil itself that was on him, or gasoline, or whatever it was he was carrying. So that also can be a chemical injury associated with that. So you're always going to make sure you stop that burning process, or exposure, or whatever that thing is. So that means you're going to wash that area with water, not cold water, because the cold water actually encourages sequestration of fluids, so those things could actually end up being problematic after the fact. Okay, so we're going to cover those areas where he is burned with just something dry. Some books say you cover it with something cool and moist, like a clean towel, that kind of thing. Now with EMS, they actually bring sheets, so they have sheets they can actually cover the patient with. So that is something that you're likely going to do with the patient. But these are going to be those immediate things we do. Always think ABCs, then you're going to address any other issues that the patient may have. They already, because he was in an accident, they put on a collar because you're trying to make sure you're mobilized, so you're looking for different types of spinal cord injuries, all those types of things for patients. You look at a neurostatus, because you don't know whether he hit his head or not, he was jostled around in that truck. So that's kind of why you do this whole thing about doing an overall assessment for your patient. Now, what kind of things do you expect to see in that first, 24 to 72 hours after the patient is injured? What are you going to see? You're going to see fluid shifts.
Fluid electrolyte come out.
So you see a lot of fluid. You're going to see fluid shifts. Where does the fluid shift from? It's moving from the vascular space into the interstitium, so that causes the edema that you see in the patient. You also have a lot of tissue injury when you talk about burn injury. When tissues are injured, they release potassium. So one of the major things you got to worry about is that patient having a high potassium level when you talk about burn injuries. Okay, same thing you see now with this one, because he was in a car accident, not only did the burns cause the problem, but crush injuries do the same thing. When you have patients who have a large crush area associated with muscle, because that's damage to them, also releases potassium. So you got to worry about that with your patient. So the fluid shift is from vascular to interstitium or interstitial, however you want to say it. So that's what accounts for the edema that you have with the patient. That also lets you know why, anytime you have a patient who has edema, it affects how medication is absorbed. So topical stuff initially is not going to be great because it doesn't get absorbed. So those will be things that we talk about a little bit later when you talk about managing your patient. But that fluid shift that you see in a patient is part of that whole syndrome, which is called burn shock. It has two phases. The first one's going to be hypovolemic, and that's that shift from the vascular space to interstitium. Remember, if you're not feeding the kidneys, they don't have blood to flow through them, they don't filter things, so you're going to see all the signs and symptoms you see with shock, hypovolemic shock. Just like you had with GI bleeding. Same symptomatology, just different mechanism by which it happens to your patient. So you're going to see urinary output go down. That's one of the kind of things you're looking for. What are those indicators that tell me, hey, what is going on with my patient? So hypovolemic shock means blood pressure is going to drop, pulse rate increases, all the same things you see in a shock patient. Urinary output goes down, and remember, the only thing the body says it has to save is your head and your heart. So everything else it sees expendable is not, but that's the way the body sees it. Okay, so you can have decreased peristalsis because nothing's going to the GI tract. You have development of ileus because that's going on with your patient. Now remember, because this fluid shift is happening, just think about you're taking all the water out of the vascular space. What does that then mean for the blood? Blood is going to be very concentrated, so they're hemoconcentrated. So that means you almost have like sludge growing through your veins. What's that going to put the patient at risk for? DVTs, PE, heart attacks, strokes. All those things can happen as a result of a burn injury with patients who have no history of cardiovascular disease. And it's mainly because you're thinking about, I'm taking away the liquid portion and all I have left is cells. And so it cannot circulate through. So those are the issues. Those are things you got to worry about because that's end organ perfusion kind of thing that's happening with your patient. So hypovolemic is the first phase that you're going to see in the patient. And the thing about it is when you talk about how a patient enters these phases, because when you read about it in textbook, it says both of these things happen within the first 24 to 72 hours. You go like, how can they be the same thing? It's because your body's going to shift, and there's no given time for any person to say how it happens. But it usually happens within those first 3 days after a burn injury. So you're going to see hypovolemic first, and then you're going to see diuretic. So you kind of think about what's happening now. The fluid is shifting from the interstitium back into the vascular space. Now I got to think about fluid overload, hemodilution. now can happen in this patient. So H&H is going to go way down. Sodium is going to go way down because now fluid's moving to the other spot. So when you see this happening in a patient, now you have to worry about fluid overload. Okay. So fluid's got to go somewhere. Yes, going back in the vascular space. Diuretic, they call it that because now the kidneys are starting to put out more urine. Okay. But fluid also goes other places. So where am I going to try to check it out? Where am I going to see it? You may see it. It may have some cerebral issues going on, so a lot of confusion, those types of things you worry about. Check O2 sat, but you also need to check the sodium, see what's going on with the patient, because remember, low sodiums, patients are confused. Patients may end up with water intoxication because this fluid shift is happening. Where else does fluid go? I'm listening to you.
Heart.
In the heart and lungs. Okay, so you may hear crackles on this patient. So who are the people you're going to worry about during that phase? Any patient who's elderly, heart failure patients, people who have kidney disease because they can't get rid of the fluid now. Okay, so those kind of people you're thinking about what's happening with your patient when that happens to them. Okay, so some of the complications that are associated with during these phases, we kind of talked about the things with fluid overload, but potassium is a big one. Okay, patient is hyperkalemic. What do we got to worry about with that? Dysrhythmias, because you can actually stop the heart when your potassium is high. So you're looking for dysrhythmias the patients have. There may be a characteristic EKG change, even though you finish cardiac, it comes back again. All right? Patients who have hyperkalemia tend to have tall peak T waves when you look at their EKG. Instead of being smooth, it almost looks just like the QRS complex, and they are tall. So that's the wave that comes after the witch hat. So it looks spiky the same. So when you see that in a patient, that alerts you that they're hyperkalemic. Okay? But that's something that you can't let continue because potassium has to be moved. Because otherwise you stop the person's heart. That's the issue that you worry about happening with your patient. If you have a person who has ileus, because that's a complication that can happen. No bowel sounds, nothing, peristalsis moving along. Okay? So that means that person can't eat or drink. And when you're talking about large burn injuries for a patient, that's one of those things. You really don't see them eating because, first of all, they can't take in enough calories that they're going to need, but that whole issue about the shifting of blood to other places instead of the GI tract is what you worry about. So ileus is something that does happen to patients. Also, when you have patients who have any type of trauma or related injury, you'll see that they can sometimes have a special kind of ulcer that we call Curling's ulcer. And that's associated with hypersecretion of acid in the stomach. So you see that with traumatic injury patients. So it's a special kind. Think about Curling with Three Stooges. It's Curling's ulcer. So how are we going to get, what are we going to do to try to prevent that?
Give PPI.
That's the person that's going to get a PPI. That's why you see trauma patients on it. No history. You know how every time you look up something, but patient has history of GERD or peptic ulcer disease. No. This is one of those things, and anytime you see patients who have these type of injuries, you want to give it to them because it's a preventative thing. So that's why you see them on that. So they're either going to be on a PPI or H2 antagonist. That's what you want to put the patient on. Those things are going to lower acid secretion in the stomach, hopefully so the patient doesn't develop ulcers, which can complicate recovery. Those are things that you're trying to prevent in your patient. Right? We talked about patients actually, the whole thing about the blood being so viscous that they can end up having strokes and those types of things. So what we have to do is actually estimate how much body surface area was burned on our patient. Because then we have to give fluid resuscitation, which is important. Because that's one of the major things you look at to see whether or not this patient is stable. Right? So you guys have to, we're going to see how much was burned on WT. You know, last night I used TV, and the student went, "Oh, prom rate." I said, "Yeah, I'm not a teacher." So I had to get a new patient today. I'm off. Okay? All right. So how much of him is burned? So he has anterior trunk. which is, okay. And then he has both arms.
36, right?
Because each arm is 9. Okay, so that's,
Oh, the whole arm is 9?
yeah. Now, this percentage-wise, what does that make it, a minor or major? That makes it a major burn, but if he just burned an arm, what would that be?
Major
It would be major because a hand is included. So hands, feet, head,
and private.
make it, and private parts, make it a major burn, regardless. If that's all that's burned, because we're talking about the percentage, that's a lot less. But when you're talking about rehab potential and people being able to do things, a lot harder when you don't have that opposing thumb. It's hard to pick up big cups with just this and nothing on the other side. So those things make a difference. Also, you think about your patients who you maybe have taken care of before who are diabetic and they take off a toe. It changes the whole way you can balance yourself just by taking off one toe. So think about that. It's rehab potential part. Major burns are 35% or greater when you're talking about body surface area burn. But also if it's a hand, a foot, face, or private areas because of the complications that kind of go along with that. So now we have to, of course, do the Parkland formula for him because fluid resuscitation is key. That what we do with this patient, because that's going to help us minimize the effects of that seesaw that's happening with that fluid shift after burn injury. It is going to happen. What you're trying to do is keep the seesaw more level as opposed to it going way out of whack, which means that the body's going to actually have to pay because you're doing that. Because if the blood pressure is too low, not only do I have the issue about patient having this process going on, but then I worry about whether that's going to be renal failure that lasts forever kind of thing in the patient. So our patient weighs, I don't know why they make him weigh 220 pounds. So how many kilograms, folks?
180 pounds.
I knew y'all got phones right now. 85?
85.45.
So how do we do that Parkland formula?
6 times.
Not 6.
No, 36.
Oh, I'm sorry.
Times the 85, and then times 4.
Right. And what fluid do we use?
Lactated.
Lactated rate. It's closest to plasma, so that's why we use it. All right. Now this is how much he gets in 24 hours. All right, Sadia.
What is
You mean you're not calculating it? I
Oh.
thought she was doing it already.
Times
12,305.45.
12,000.
305.45.
So this is how much he has to get in the first 24 hours. Rarely do you give people those kind of fluids, but in burn patients, you see it all the time, and even more. All right? So how do we apply the Parkland formula? Parkland says he gets what?
Half for the first 8 hours.
And if he was stuck in the truck for 2 hours, then within 6 hours.
Huh? Don't need a lecture.
So that's the application of how we do Parkland.
I'm on lecture last week.
All right? So that's what we have to do. We got to give him this much fluid. He gets half of it the first 8, a quarter the second 8, quarter the last 8. So that's the application of Parkland formula when you're talking about with the patient. Now we have to say how fast we're going to give it to him. And Sadia is right. The clock starts ticking when the patient gets hurt. All right, so it took them an hour to get to him, so you only have 7 hours to give him half. Always, even though they were giving him stuff at the scene, they always counted from the time the patient is presented and we're going to use it. So that's great that he had some fluid resuscitation, but usually in the field they're going to hang on saline. So what we want is lactated ringers. So when the patient gets there, that's when it's going to count. So time of injury means that it took him an hour to get to him. So you're saying I have 7 hours to get there. All right. So you're gonna divide this by 2, and then that's gonna be what you're giving the patient for the first over set, and then you have to divide it by 7 to see what your rate of infusion is gonna be with the patient.
So,
You divide that total number by 7 right there?
No,
Oh.
you're gonna divide, because he's getting half of this.
Oh,
So it's 6,100 and
150,
oh,
52 point.
okay.
okay.
So that's how much he's gonna get, but if you wanted to see your rate of infusion, you have to divide that by 7.
Because he was stuck in the truck for an hour.
Because the example I gave to the person last night was that he was stuck for an hour and a half. So they only had 6.5 hours to give him.
So then you divide it by 6.5, right?
Right. So however much time that person was caught somewhere, you have to consider that in the time. Because what you're trying to do is keep the seesaw like this instead of it going way up and down. The other thing is you're going to be looking to see if it's effective. Because how do you evaluate when you use the Parkland formula? There's several things you look at. You're looking at urinary output. You want at least 20 mLs per hour that the patient is putting out in urine. At least. There are some patients we want way high. That's the patient has electrical injury. You want their urinary output 40, 50, 60 cc's per hour. The reason being that as tissue is damaged, even though you talk about this tissue damage that you have with the burn injury, electrical injuries produce myoglobin, which is a large molecule that can't filter through the kidneys. So I want you to be putting out more urine to try to dilute it so you don't have damage to your kidneys. So you want them having a lot of urinary output. Electrical injuries are deceiving because you never know the extent of injury, sometimes for days later, because electricity always follows the path of least resistance. So you're going to have a patient with an entry wound that's very small. So say it goes into somebody, but it's going to come out big. So it's going to shoot something off. It's almost like shooting a gun into somebody. We had a little girl one time when I was working at St. Joe's that came in with a electrical burn injury. Okay, she looked perfect on the outside because she was out camping. It was raining. She was in a sleeping bag on the ground. Lightning hit the tree, traveled through her eardrum, out through her foot. Her toes were blown off. Whew. But you don't see anything except her toes being blown off. So you don't know what other damage has gone there until later. That's the thing you have to worry about with electrical injury. The other piece about them is if you stay in contact with whatever it is, that is the person that dies. Because if you stay in contact with current, it continues. Basically, you're doing defibrillation to your heart, ongoing. Okay, so if that's why people who, if they're in those cherry pickers and fall out of it, you know, it's horrible because you're going to have pelvic fractures, all this kind of stuff going on. But you lose contact with electricity. That's the person that is likely to live. Because when you hit the ground, guess what? That's a precordial pump. Puts you out of that fibrillation for a lot of people. I know that's madness, but that's how people live. Because my brother talks about it a lot too, because he works for Chico, and he was talking about one of the guys one time was doing something to a transformer, and the door blew against him and knocked him inside the thing, and nobody was there to pull him out. So he just burnt up, kind of thing. But it was because he was in contact with the current for all that time. So there's nothing you can really do for people like that. So that's something that you don't ever want to happen, but it is one of those things. Electrical injuries, you don't know the extent of injury sometimes until a lot later. And the dysrhythmia piece doesn't happen always immediately. So that's why usually if you have a patient who's been struck by, because we see about people struck by lightning, may not get a direct hit, but they were on the beach. You know how we tell folks if you can hear it, you don't need to be outside. But when you have people from out of town, they think, oh, it's great. You know, kind of thing. They get struck. Oh my God, I'm going to die. It's those traveling folk. They go out to the beach. We know, you know, especially if you grew up in a black household, you turn everything off when lightning starts coming.
No showers, no.
Shut up.
That's it. That's it. I always tell you, go sit down and be quiet. Shut up. Well, you got 7 kids. You're looking at what? You don't know how to be quiet. What are you talking about? But that's the thing. You know, you can go somewhere and be quiet, but people go walking on the beach kind of thing, thinking it's far off. I don't see it. But if you can hear it, it's too close. That's what they always tell you, so you need to be inside. But those people go to the hospital, and they stay there for 3 or 4 days and wonder why they're still there. It's because we don't know yet what injury has happened to you. Sometimes those are arrhythmias that happen with your heart. Don't happen that day. They happen a couple of days into your hospitalization. That myoglobin, we don't know about those kind of things that happen with a patient. So we look at those to make sure the patient is okay before you send them home. Okay. But to see if this Parkland formula has been effective, we look at urinary output. We also look at vital signs. Okay. You want that heart rate between 60 and 100, because over 100 tachycardic means this patient is not as stable as I want them to be. It could be because we haven't given enough, or there may be some other things going on, but you know you want to keep that blood pressure up, keep up MAP, because that perfuses things, so you want to make sure that heart rate stays up, between 60 and 100. You also want the blood pressure to stay above 100 systolic, because that's usually what tells you MAP is going to be okay when you actually calculate it out for the patient. So you're looking at those things. You're also looking at mentation. Okay. Patient's going to still hurt, but if you're perfusing the brain, they talk to you. They're alert oriented. They may not be able to talk to you because they have something in their mouth, because you may have a tooth, depending on what's happened with your patient, but they respond. You know, some people blink, all kinds of things we work out with patients to kind of see if they're with it, but you're assessing all those things. You look at level of consciousness to see how the patient is doing. So those things kind of tell us that Parkland has been effective. Now, one of the things to kind of remember, we do this whole thing about lactated ringers that first day. That's all you're going to ever see given. The second day, they might end up adding other things, like the crystalloids, colloids, those types of things. Hep span, if the patient's still not responding to what you're doing in fluids. That's why burn treatment of patients who have burn injuries is very specialized. And after 9/11, we figured out how bad we were as a country about the specialization of burn injuries. Because all of the Southeast actually has more people in it than any other part of the country. When you talk about, because we've had so much growth over the years. But we only have 142 burn unit beds for all of the Southeast. So if something happens, there's only a few places you can go. And I'm telling, when I got out of nursing school, I thought that's what I wanted to do. I went to work in the burn unit and stayed 3 months. Could not deal with it. Because first of all, back then, all your ICU units were closed up areas. And then you had trace and sputum. Okay, the aforementioned sputum, that's part of that. But the other thing is you had to scrape people every day to do wound care. I could not handle it. Whew. I was like, oh my God. But you know you're helping people. I said, oh no, I can't do this. I gotta go. You're helping them get better. No, I can't. Can't do it. Thank goodness there's somebody that can do everything, because that was not, it was so exciting to me, the thought of it. And so much stuff now is so interesting about what's going on with burn care in patients. It really is interesting, but man, I can do it still to this day, kind of thing. It's rewarding work when you have patients who go home, and we're seeing all the things that we do now with cultured skin and all that kind of thing. That guy who was on Dancing with the Stars, why they call him the $600,000 man, not $6 million, but he's close to $1 million because he had all these different types of